I was given a slightly easier task. I was asked to address the question, which neonatal ventilation technique reduces bronchopulmonary dysplasia? And of course, that's been the holy grail for neonatologists since BPD was first diagnosed. What I'm going to show shortly is, though, that's the wrong question because it's the wrong outcome. And I'm going to address a somewhat different question, but and hopefully come to some answers. Before I do so, I just want to orientate you where I come from, which is obviously clearly London. This is the tallest building in Europe, the Shard, and arguably the most beautiful. This is the Guy's Hospital Tower, where I work, as well as at King's. It is the tallest hospital building and indisputably the ugliest. So this is a baby who appeared on the front page of one of our newspapers at 23 weeks of gestation. She was on her route home. And as you can see, she's chronically oxygen dependent. So by anybody's definition, she's got bronchopulmonary dysplasia. And therefore, survival without BPD has been frequently used as the outcome of RCTs in neonatology, or BPD per se. And that begs the question that BPD predicts long-term respiratory morbidity. Yet the 10 neonatologists in the audience and myself all know that babies without BPD develop long-term respiratory morbidity. And so the question one would ask is, does BPD predict long-term respiratory morbidity? And I'm deliberately going to show you two old slides because actually we've known for 20 years that's not the case. This is a study that will be known to the neonatologists, vitamin A supplementation, huge excitement because there was a significant reduction in bronchopulmonary dysplasia, which then turned to dismay when the babies were followed to 18 to 22 months and vitamin A supplementation had neither reduced hospitalization or pulmonary problems after discharge. Around the same time, there was a study looking at recombinant human superoxide dismutase, and the initial analysis showed no significant differences in death or bronchopulmonary dysplasia, but at follow-up, in the most immature and at high-risk group, there was a significant reduction in recurrent wheeze at follow-up that required treatment. So completely disconnect between BPD and long-term follow-up. If I fast forward you, we've used data from the United Kingdom oscillation study, which I'm going to tell you some more about later, to actually say what predicts respiratory outcome at 24 months. Is it BPD, using the two commonest definitions, or is it a very simple definition of respiratory morbidity, which was just collected by parents filling in diary cards? And the definition was that they had to wheeze, cough, or take medication on 3 days per week for a 2-week period. So we were excluding babies who just had a viral infection. And then we analysed the data, obviously, by using areas under ROC curves. And what you can see, regardless of the outcome at 2 years, this simple definition at a year performs significantly better at BPD 28 days or 36 weeks. I'm not showing you the data. Indeed, BPD was about as good as a predictor as tossing a coin. So what I'm actually going to do is answer the question is, which neonatal ventilation technique reduces long-term respiratory morbidity? And sadly, for the neonatologists in the audience, you all know that there are very few data which I can draw upon. So nowadays, there's a great drive for us to use non-invasive techniques of respiratory support. And we've got 3 very large trials to inform whether that drive is correct or not. This is the COIN trial, in which babies were entered at birth if they were sick enough to require respiratory support, but not sick enough to require immediate ventilation. So this trial took forever to complete and showed that there was a reduction in BPD at 28 days, but not at 36 weeks, and a horrendous increase in pneumothorax in the CPAP group, which I think any of us would be embarrassed to say was our own incidence. And this may reflect reduction in use of prophylactic surfactant or the high CPAP level of 8 centimeters that was used. There were then later 2 studies which had very similar design. One was prophylactic surfactant, intubation and try and then extubate the baby, or selective surfactant when CPAP when CPAP failed. And you will notice the CPAP failed in nearly 50% of the infants who required surfactant at 4 hours. And what the outcome of this study was that the primary outcome, mechanical ventilation in the first 5 days, didn't differ between the two groups, and there were no significant differences in other outcomes. This was a slightly more complex study. It was a 2-by-2 factorial design. The other half of the study was about looking at different levels of oxygen saturation, but the one I'm going to talk to you about is again early intubation and surfactant, or CPAP and surfactant when that failed. Of course, by the study design, this group got more surfactant, were more likely to be ventilated in the delivery room. But in terms of the primary outcome, BPD or death, no significant difference. However, in this study, there was a follow-up, the breathing's outcome study, and the babies were followed to 18 to 22 months. And here we start to see a benefit. The CPAP group had fewer wheezing episodes, less respiratory illnesses, less emergency room visits. So again, a disconnect, no significant reduction in BPD, yet an improvement in longer-term outcomes. Then we've got a systematic review of volume-targeted ventilation. This is different from the Cochrane review in it shows a reduction in bronchopulmonary dysplasia. I, however, find this meta-analysis difficult to interpret because 2 of the studies are exclusively in Chinese, and it's not one of my other languages, I'm afraid. And so it's very difficult to tease out what was going on in those studies. Of all of those studies, only one has had a long-term follow-up. This is the study from Middlesbrough, in which they looked at volume control ventilation versus pressure control. The only significant thing they could do, as they data dredge, a significant outcome they could find, was in the babies less than 1,000 grams, there was faster weaning, no reduction in bronchopulmonary dysplasia. Yet when they followed the patients, the volume-controlled arm, which I'm going to speak of more this afternoon, had tendency to lower readmission rates and less treatment needs, with no significant differences in neurodevelopmental outcome. So again, a disconnect. The thing I want to spend a bit more time on is prophylactic high-frequency oscillation. So this is looking at the oscillation in the first 12 hours of age. And in the 17 studies that are in the English literature and American literature, there is a significant difference in bronchopulmonary dysplasia at 36 weeks or discharge. And importantly, no significant differences in adverse outcomes. But for those who know the details of this meta-analysis, the studies within it are of different design, different machines, and often the positive trials, oscillation was compared to an inferior form of ventilation, such as SIMV. And more importantly, the subsequent patient-level meta-analysis did not show a significant reduction in bronchopulmonary dysplasia. Within that meta-analysis is our own MRC-funded United Kingdom oscillation trial. And it uniquely tested a hypothesis that there was a golden period after birth when you could either damage or protect infants' lung function. And this was in the first 60 minutes. The babies were randomized, they were very immature, and despite randomizing 700 infants, there were no significant differences in the primary outcome. So to look at that further, we completed a year or so ago the Yukos follow-up study. And we specifically asked, does neonatal high-frequency oscillation protect small airway function in children aged 11 to 14 years? And we chose that age because we thought they could do comprehensive lung function measurements. The children, the parents, and their teachers filled in respiratory health quality of life and functional questionnaires. And they undertook comprehensive cardiopulmonary assessments. This just shows some of the suite of lung function measurements we undertook. Our primary outcome, however, was small airway function. This suite of lung function tests, the questionnaires, and assessment by echocardiography took 4 hours per child. So you can imagine we were somewhat dismayed when the statistician said the planned sample size was 320. Now, why were we dismayed? Well, if you think about it, we've got a very immature group of preterm infants, so they're likely at least to have learning problems, if not frank cerebral palsy. But we had a secret weapon. And our secret weapon was our research nurse, Mariah. And for those of you in the front, you can see that she is forcibly showing how a child should breathe into the spirometer. You can see his brother's got it, but sadly he hasn't. Thankfully, with time, he did get it. Our other problem was that the patients had been recruited from all over the UK and Southern Ireland, and we had to bring them back for quality assurance processes to King's College Hospital. So we developed a website, a newsletter, but again we had another secret weapon. One of our ex-Yukos patients and her mother, who'd always been keen for us to do follow-up, and they therefore went on a variety of social media advertising the study, and the study so-called went viral, so really emphasizing the importance of PPI into clinical trials. And we managed to recruit to sample size and to time, including what seemed at the time a bumper set of quads. But I don't know how many of you do lung function, but can you imagine doing 4 hours on 4 12-year-old boys? They enjoyed themselves immensely and went off to go on the eye after we'd finished. The researchers were exhausted and went off to the pub. Now, I'm just going to show you 2 of our results slides, because as you can see, the data were published in the New England Journal of Medicine. This is a deliberately busy slide. What it's showing is some of the aspects of lung function that differed significantly, and these are shown by figures in red. And the primary outcome is significantly different, as is other aspects of airway function, including, importantly, this non-volitional technique, which of course we couldn't influence. The differences, when adjusted for confounders, are relatively small. They are all in favor of the oscillation group. As I say, the differences are small and perhaps may account for why the children in the conventional group weren't more symptomatic. This is looking at educational attainment and educational provision. Same format, again, these are statistically significant. The differences were in art and design, IT, and design and technology. And those of you, the neonatologists in the audience, will know that is all assessing visual spatial ability, which is the thing that is most commonly deficient in premature infants. Again, all the significant differences are in favor of the oscillation group. And indeed, there was almost a significant difference for the oscillation group to receive less special education needs support in school. So what do these results actually mean? Very premature birth results in chronic respiratory morbidity regardless of BPD development. BPD is not the best outcome measure for RCTs, but we are seeing now ventilatory interventions influencing chronic respiratory morbidity. VTV and CPAP need longer follow-up, and certainly with prophylactic oscillation, we need to see if these results are maintained post-puberty. And I'd just like to finish by acknowledging the Yukos team. I didn't do it by myself, there was many of us, and obviously our funders. Thank you very much for your attention.
Thank you very much, Anne, for a terrific talk. You certainly have a lot to teach the adults on how to use high-frequency ventilation, I'm afraid. Any questions from the audience? Maybe I can start. Very impressive. The long-term studies are clearly very impressive, but they're also a little bit scary. Yeah. Because if we have to wait 15 years to see if a therapy is effective or not, first of all, it's going to be long and difficult, and then when do we start to use a new therapy? Do we have to wait the 15 years? So can you give us some insights into the implication of sort of long-term follow-up?
Okay, you're absolutely right, because we can't afford to wait that length of time. I mean, thankfully, in the period of this study, neonatal things had not changed that much. These babies all had antenatal steroids and postnatal surfactant, but the neonatal field moves on fast. So what we've been really developing is what are the measures at 1 and 2 years that will really tell us that are a predictor of long-term respiratory morbidity. And we think it's some very simple things about symptomatology. We're also looking at lung function outcomes. Because again, funders are not going to fund trials that go out to 15 years in the first instance, but we're confident that we're going to be able to develop markers at 2 years of age, which will tell us whether a technique will or not protect long-term lung function. But I think the follow-up studies are very important to tell us what's going to happen. I predict that some of these babies are going to very early on develop COPD.
Question?
It's a very nice talk. I'm curious about the increasing use of non-invasive ventilation and the increasing CPAP levels. Like, could you give some comment on that? And especially I would like to see there be an experimentalist mostly, seeing like what happens to hemodynamics in very soft rib cages and so on.
Yeah.
And I mean, HFOV usually goes with fairly high CPAP too. Could you comment on this, please?
Yes. Well, I think, the problem that we've got is that we have not got an easy technique for measuring lung distension, particularly during high-frequency oscillation. We routinely measure FRC on the babies and would titrate accordingly. But I think the fashion to put these babies on higher and higher levels of nasal CPAP is inappropriate. And I think that's, the only thing that the COIN trial probably told neonatologists, that if you use 8 centimeters of CPAP, because you're stimulating the Herringbroyer reflex and the babies are going to get more pneumothoraces. So I think it's absolutely wrong. But what we do need is a technique that will reliably tell us whether the lungs over-distended during high-frequency oscillation, and other techniques, because, we can measure FRC with helium gas dilution, but it's not a standard thing to be able to do. So I totally agree with you.
Great, thank you very much.